confirm that my screen is visible?
It is visible, sir. It is pretty much clear.
Yes, that is absolutely visible.
Okay, thank you. Good evening, everybody, and it's a pleasure for me to be part of this edition of the RSSDI National Conference of the year 2021. I fully realize that this is a power-packed program and a lot of very high-end presentations before and after what I will be presenting. But after much thought and deliberation, I decided to take on a very, very simple but clinically relevant area for my talk this evening. And that is self-monitoring of blood glucose, current evidence and implications for clinical practice. Let me at this point actually make another clarification that I will not be talking about the more recent methods of monitoring, including sensors and the range of very interesting and new parameters, including time and range, etc. I will resort to speaking on capillary blood glucose testing with the full understanding that there is a large part of our patient population who doesn't even do this, thereby impacting on their ability to manage their diabetes well. So I will take this lecture in the following components. Why is self-monitoring of blood glucose important? Issues related to the accuracy of this, of the various techniques which are in use. Then more specifically, what is the evidence that Smbg actually improves the ability to manage both by the patient and by the healthcare professional, and whether it actually improves hard clinical endpoints. Because eventually, remember, these are all tools and media to reach at our final destination, which is better patient outcomes. We'll then go ahead to talk about recommendations from various guidelines and end with pattern management and structured Smbg, because again, that is important for the context in which we advise patients to take on Smbg. Very briefly, monitoring blood glucose is without doubt the optimal way to confirm and appropriately treat hypoglycemia. In fact, if you go back to the history, and this is an important area because we are about 100 years into the discovery of insulin, when insulin was introduced, especially for type 1 diabetes, people felt that we now have a cure for a potentially fatal disorder. And then really what happened was that people, after starting insulin, still continued to develop microvascular complications, develop significant hypoglycemic episodes, till it was realized that insulin on its own is not a panacea for the treatment. The basic emphasis has to be, again, that insulin is a tool to reach good glucose control, and that monitoring is a very important part of that glucose control. It would surprise a lot of the younger people in the audience that it was only in the 1970s that two very pioneering German clinicians, Berger and Mühlhauser from Düsseldorf in Germany, actually showed the fact that you can transfer monitoring to the houses of patients, and that patients can utilize this information to titrate treatment and their lifestyle behavior. It took perhaps another 30 years before this became standard clinical practice. So Smbg is critical. It is central, whether it's used by capillary blood glucose or, as we said, it's used more recently using interstitial glucose, either in real time or as flash glucose monitoring. But my talk will be primarily on Smbg using capillary blood glucose. It provides feedback on the results of behavior and pharmacological interventions. It definitely increases patient empowerment and adherence to treatment. It provides information about day-to-day, hour-by-hour fluctuations in blood glucose levels, especially in relationship to meals and exercise. It helps intensify blood glucose control during physical activity and acute illness. And even more importantly, for a large bunch of patients who especially have developed hypoglycemia unawareness over a period of time, it detects clinically silent hypoglycemia. Now, when we use a meter, we need to be sure that the meter is accurate, right? There is no point using a device or a tool in which we don't have the confidence that the value that it provides us is useful. And we encounter this problem on a day-to-day basis. And keeping this in mind, the FDA in 2016 came up with prescribed parameters which need to be confirmed by manufacturers before their meter can be approved for use. Now, for meters for personal use, 95% of the results should be within 15% of the comparator method. And in fact, 99% should be within 20% of the comparator. But even more stringency is required if that meter is used for professional use. For example, if you use the same meter for in-hospital or intensive care or HDU care, we need an even more accurate meter. In this instance, the prescription is 95% of the results should be within 12% of the comparator group if the glucose levels are more than 75 milligram per deciliter, and it should be as tight as plus minus 12 milligrams per deciliter if the sugars are below 75 milligram per deciliter. 98% of the values should be within 15% of the comparator method for blood glucose if the values are more than 75, and it should be plus minus 15 milligram per deciliter for levels less than 75 milligram per deciliter. Please keep this in mind that this is what is demanded by the FDA. The ISO has a bit more simple but comparable prescription. 95% of all meters, irrespective of whether they're used for personal use or in hospital use, should provide values within 15% if the glucose is more than 100 milligrams per deciliter, and it should be within 15 milligrams per deciliter for blood glucose less than 100 milligrams per deciliter. Please also remember that there is no formal reevaluation of meters once that device has received clearance to ensure continued device accuracy. So this is a very, very important point when we are selecting meters. What can be the sources of error? Now, these are simple things which everyone knows but often ignores. The strips could be damaged because of excess temperature and humidity, which is common in India. The other thing, we keep talking of expiry of the test strips. Now, if the test strips are individually wrapped, there is a formal expiry which is provided. However, in a bottle with open strips, while the bottle itself has an expiry date, the strips within that bottle actually are potentially malfunctionable if they exceed a month after opening that bottle of strips. So we must remember, expiry is not just merely what is written outside, but also with reference to opened bottle containing non-individually wrapped strips. There were other issues with glucometers which were really valid only for older meters, but even with newer meters, electromagnetic interference in which from the mobile phones has become a big problem, and we must maintain a distance of about 1.5 feet from between the meter and a mobile phone. Other issues which are relevant is hematocrit. Anemia and low hematocrit can give rise to higher readings, lower oxygen tension, which is in hypoxic conditions can result in higher values when the method used is glucose oxidase, and of course extreme pH situations, which are extremely rare but can happen in the emergency units if a patient comes with DKA, can affect the enzymatic reaction. The other issue is, and we don't realize that, and that is interfering substances, of which maltose, especially in patients who are on peritoneal dialysis, either continuous or in hospital, because the peritoneal dialysis solution contains icodextrin, which gets converted into maltose. And that maltose is often misread by meters and strips which use glucose dehydrogenase methods with pyrroloquinoline, quinolone as a cofactor. And I'll speak a little bit more about this because it is important for inpatient management. So by and large, the enzymatic methods that we use today are two categories: glucose dehydrogenase, which is an amperometric method, which means it results in a change in electric current, and this change in current is what is being picked up, or glucose oxidase, which could either be amperometric or colorimetric. Now, glucose dehydrogenase doesn't interfere, is not interfered with oxygen tension changes. However, the issue about false positive measurements, if the GDH, PQQ, so the glucose dehydrogenase can have either NAD as a cofactor, FAD as a cofactor, or as I said, PQQ as a cofactor, and that is still being used in several meters. Now, these are fine in a vast majority of patients, but in specific situations, as I mentioned, when the person is on peritoneal dialysis and has icodextrin in the peritoneal dialysis solution, the patient is receiving IVIG, there is hereditary galactosemia, again rare, but cases have been reported even from India. Glucose oxidase is prone from interference with hypoxia, that is more selective for glucose than GDH. So everything has a positive and a negative, and we must be aware of that. I'm just going to give you an example of the GDS PQQ glucose monitoring technology. And this is a patient whose clinical course was unfortunate, right? So this patient was admitted and found to be unresponsive. The blood glucose as measured by a meter which used GDS PQQ was shown to be 193, but the sample sent to the laboratory was showing a low sugar of 8 milligrams per deciliter. You can see the degree of misreporting. Third day, again, the same problem happened. Two values were seen, both by the same meter, 363 and 148, and ended up with a hospital lab value, which is only 10 milligrams per deciliter. And eventually the patient was comatose, went on ventilator, and then died, right? So there are multiple episodes in the same patient who was on peritoneal dialysis containing icodextrin in the solution, treated with insulin because of an erroneous value, causing hypoglycemia and death. And the FDA has now recommended that practitioners avoid using GDH PQQ technology, and let me clarify, in healthcare facilities, or take steps to never use them on patients receiving interfering substances. Now, what about accuracy of the available blood glucometers? And I will not, it's not about saying that, meter from A company or B company is good or bad. This is a study which was published in Journal of Diabetes Science and Technology in 2017. Essentially what it shows that the minimum absolute relative difference, the mean absolute relative difference between the meter and the comparative method actually ranged from as low as 5% to as much as 20%. And we've already talked about 15% as a cutoff. 5 out of these 17 meters actually went above that threshold of 15%. Higher MAD values and a wider spread was seen in the hypoglycemic range, but it was still persistent and significant in the higher range. People often feel that anything more expensive is better, but there was no correlation between the cost of strips and accuracy. This is, again, another one which compares Contour Plus, which is a meter which is available in India, with 4 blood glucose monitoring systems. So if you now look at the method, you'll find that there is a persistent use of PQQ with GDH in a couple of meters. 2 of them are GDH using flavin-adenine dinucleotide, and 1 of them is a glucose oxidase meter. Clearly, this one, despite glucose dehydrogenase, when it uses FAD, very, very good mean absolute relative difference, about 3 to 4%, which is exceptional. The one right at the bottom goes to as much as 14, 15, and even 17% on occasion. So really, one must look out for the meters which we are purchasing and using to be sure that they meet the criteria. Now, this was tested. Now, when the same meter may have been approved by the FDA, they may not really have had a value exceeding 15% because it would not have passed the test for FDA to give approval. What are the sources of error beyond analytical? Of course, contaminated surface, unwashed hands, food residue, sampling error in the form of improper lancing technique, inadequate volume, squeezing fingertips, which means basically we don't get capillary blood out, we get an excess of plasma or serum out. Alternate sites, which are sometimes used because patients complain that their fingertips pain too much, like the forearm, palm, and thigh, are less reliable, especially when there's a rapid change in blood glucose. Others, of course, we already mentioned, hypotension, vasoconstriction can also contribute to analytical errors. Post-analytical errors could be a very simple error in reading the glucose value due to vision problems, incorrect recording, and this is not uncommon in the sort of clientele I deal with. I look at people from a less affluent background, not very often educated, so they may have educational issues which are preventing them from actually recording it properly. Of course, people also fudge the log, right? Deliberately trying to give a value so that they don't get into trouble when they see the doctor, and poor legibility when they write it down. And of course, in the current day meters, which can transmit to the phone, there could actually be errors in transmission to an electronic database because of software issues. Finishing this component, I think it's important to understand what are the data to show that Smbg use in type 1 and type 2 diabetes brings benefit. Because unless it brings benefit, there is no point even looking at it. So let's start with a DCCT trial in which intensive insulin therapy was guided by frequent Smbg and clearly delayed the onset and slowed the progression of microvascular complications. About 15 years after that study, it was again demonstrated that focused Smbg intervention in suboptimally controlled patients can improve HbA1c compared to regular guideline-based care. Now, I don't think there's any doubt in our mind that Smbg use in type 1 diabetes is of any question. It is to be used. The only issue which comes up in mind is how many times in a day. So I'm just quoting from two very large studies. One is from the Type 1 Diabetes Exchange, which is nearly 21,000 participants of type 1 diabetes, more than 1 year in duration. Very clearly, the higher number of Smbg measurements per day was strongly associated with a lower HbA1c, irrespective of the age and irrespective of whether the person was using pumps or injections. Ziegler et al. From the German-Austrian database again demonstrated that frequency of Smbg was significantly associated with better metabolic control. And for every additional test done on a day, the HbA1c was reduced by 0.2%. So the message for type 1 diabetes is very clear, must be used and must be used as frequently. And we'll come to recommendations in a moment. Now, for type 2 diabetes, there is a little bit of confusion. For insulin-treated type 2 diabetes, by and large, the evidence is clear and supports the use of Smbg, very similar to the use of Smbg in type 1 diabetes. This was shown in the Kumamoto study, in which intensive insulin therapy guided by Smbg reduced microvascular complication, and the more recent Dove study, in which intensified Smbg improved glucose control. However, it is pertinent to point out benefits were only seen in patients whose Smbg compliance exceeded 75% of what was recommended, or those who had a high baseline A1C to start with. So well-controlled patients may not benefit as much by Smbg in a rigorous and aggressive way as it would as other patients. The problem happens when you look at data on Smbg use in non-insulin treated type 2 diabetes. Patients who are on oral agents, sometimes even within oral agent categories, patients who are on metformin on the one hand and insulin secretagogues on the other hand. Now, I'm just going to take you through some of these studies. For the one on the Duran study in 2010, clearly showed that an Smbg-based intervention versus A1C-based control group, there were higher rates of diabetes regression. That is, that A1C became lower than 6%, and remission, that is, A1C was between 6 and 6.4% in those who use Smbg. In the Allen and Bazargan-Hijazi study, the differences in decrease in HbA1c levels in those who use Smbg were not statistically significant. In the study by Barnett et al. In a multi-center randomized parallel group trial, Smbg group led to a decrease of A1c and also had a lower incidence of symptomatic hypoglycemia. In the O'Kane study, a prospective RCT, Smbg versus no monitoring on glycemic control, there was actually no difference. And finally, in the Schwedt study, which was published in Diabetes Care, per protocol analysis, you showed that the use of Smbg significantly reduced A1c, but they could not differentiate whether this was because of intensive therapy or because of Smbg on its own. A more definitive study, which was actually done in England in about 15 years ago, was a 4-year-long study, right? Most of the other studies were short duration studies and up to a maximum of 1 year, but 4-year-own open randomized 3-arm parallel group trial. One was the usual care. Remember, these are patients of type 2 diabetes without being on insulin, just measuring A1C. Secondly, using a glucometer with the advice for participants to contact their doctor for interpretation of results. So it wasn't self-management. And the third was using a glucometer in which they'd been trained to interpret, apply, and modify. Interestingly, at 1 year, the differences between the 3 groups was not statistically significant. So if you now look at the overall evidence of Smbg in type 2 diabetes in non-insulin treated patients, the meta-analyses clearly seem to indicate that there may be some benefit in the short term within 3 to 6 months, But at 1 year and beyond, there is really no difference whether or not you use Smbg. And actually, it is associated with diminished initial quality of life and is unlikely to be cost effective. So I think we need to be very careful about prescribing Smbg in oral agent used in people with type 2 diabetes. Now that we've established this, what is the frequency of testing which is recommended? Let's break it down into type 1 diabetes and type 2 diabetes. The ADA in 2020 has clearly said that at least 4 times a day in type 1 diabetes. Remember, type 1 diabetes in the US is treated either by analog insulins or by pumps, and carbohydrate counting is a central factor. Now, if you're using carbohydrate counting, you need to do a pre-meal sugar because you need to apply a correction if you're not at pre-meal target, and you've got to give a dose depending on the carbohydrate count. Now, carb counting is not universally followed in our country because patients sometimes cannot monitor so frequently. And secondly, because food labeling is not yet completely available. Also, the educational status of our patients may not always be consistent with using carb counts. And therefore, in India, you may not restrict yourself to just pre-meals. You may also consider pre and post meals because you're looking at a standard diet, which is a standard prescribed caloric intake and carb intake. And you really want to see what the delta value is. That is, what is the change in post-meal to from pre-meal with a certain dose of insulin with a certain meal. In addition to the pre and post meal debate, the frequency of testing may vary based on individual needs. Relatively constant behavior, lifestyle, frequency may be 4 times a day or even less. But those who have an erratic lifestyle, those who are on pumps, clearly demand more frequent testing. And of course, those with hypoglycemia unawareness must test more frequently. In addition, whenever low glucose is suspected or when you've corrected low glucose, you must test. And therefore, very often you may be asking patients to check as much as 6 to 10 times a day. But clearly, most of our patients do not do that. So in regards to type 2 diabetes, the ADA recommendation is relatively clear. Regimens which do not include insulin or an insulin secretagogue, blood glucose monitoring is not recommended. However, when you're altering treatment, when there's symptomatic hyperglycemia or there's an acute illness, you may temporarily advise self-monitoring of blood glucose. In regimens which include insulin or insulin secretagogues, you may, especially basal insulin, you may start some monitoring. But once you go to insulin in a type 2 diabetic, you will do testing as frequently as you would do for a person with type 1 diabetes. For women with GDM, you will use 4 times a day when they're on regimens without secretagogues or insulin. Then you can cut it down. But with basal bolus insulin, you will do it as frequently as type 1. So once you're on multiple subcutaneous insulin injections, you must monitor as frequently as in type 1 diabetes. Does the ACE give us another advisory? Well, very similar. Type 1 diabetes adults, 6 to 10 times a day, pre-meal, occasional post-meal, before exercise or critical task, and at bedtime. In the pediatric age group, they've reduced it to about 4 times in a day. In those who have type 2 diabetes receiving either insulin, which is basal or sulfonylureas or insulin secretagogues, a structured blood glucose is recommended. They've not tried to differentiate too much between the secretagogues and the insulin, but clearly the moment you go on basal bolus, they will say at least 3, 4 or more times in a day. Gestational diabetes, the frequency remains the same, except that instead of a 2-hour postprandial, they are looking at a 1-hour postprandial value because it helps decide the insulin regimen. The International Society for Pediatric and Adolescent Diabetes in 2018 clearly said that unlike the ADA, which talked about 4 times a day for children, they've upped the ante to 6 to 10 times a day. And again, this will vary during the day before meals and a snack, 2 to 3 hours after food intake to determine appropriate meal doses. Exercise, which becomes a very important part for the children at bedtime. Of course, if the adolescent is starting to drive a car, and then definitely during intercurrent illness to prevent hyperglycemic crises. Let me come to the last bit of my presentation, and which is a very, very critical part in this day and age when everything is done digitally. Sensors transmit information directly to phones, meters transmit information to phones and or to physicians. There are a lot of patients who still cannot use that technology. Record keeping manually becomes a very, very important part of this, and therefore it's essential for us to be aware about this so that we can manage our patients who belong to that category with this method. So the record book clearly needs to have the glucose levels according to the time. So pre, post breakfast, pre, post lunch, pre, post dinner. The carbohydrate intake, if it's possible, or at least a mention of what the food intake was, the insulin dose, note of special events. So what we say, comments. Comments are a very critical part of record keeping, not just merely measuring the sugar, but trying to explain aberrant values above and below by factors which could have caused those values, whether it was an early meal, late meal, larger meal, smaller meal, atypical content of the meal, atypical amount of exercise, whatever it is, stressors. Hypoglycemic episodes should be explained, and episodes of hyperglycemia and ketonemia and ketonuria must be documented. So the recording is not limited to just putting down the glucose values. It involves clearly charting of the values of the insulin, of the meals, of exercise, of atypical events in their lifestyle and in the daily routine, and comments clearly indicating possible explanations so that these can be interpreted and these can be addressed by the patient and or by the physician. And therefore, the Association of Diabetes Care and Educational Specialists have clearly said pattern recognition and pattern management are very important parts. Searching for patterns in blood glucose data to identify opportunities to improve glycemic management is a critical part. So if in the clinic, if a patient with type 1 diabetes comes with only their sugars recorded, no comments written, I ask them to go and see the educator once again. Blood glucose monitoring will help identify the effect of food choices. So if you had 2 rotis instead of 2 idlis, instead of 2 dosas, there may be a very different hike in the post-meal sugar, even if the carb content was similar, because the GI, GLs change. The same food, in addition to a high fiber, additional food item may give rise to a very different post-meal peak. Documenting physical activity, stress, and other medications. So in COVID, the addition of steroids really made a huge difference, and people, stable diabetes went totally out of whack. Patients with diabetes and their diabetes care providers need to be educated how to interpret individual glucose values, the patterns which are visible, and explain how they can do a self-adjustment of their insulin dose, right? The paper logbooks or digital apps, whatever are available, are needed to collect this information, analyze this information, interpret this information, and inform management in terms of dose modification. Very, very important. We tend not to do that altogether. I'm going to wind up by giving you 2 or 3 examples of pattern management just to leave you with this thought. So let's take a standard person of 20 years who's got type 1 diabetes, who's on basal bolus regimen, like treating people from a less affluent caste. I still use regular and NPH, so conventional insulins, and this is the log. So you're seeing paired readings before and after each of the 3 major meals and a 3 AM value. What is striking is that there is a dramatic dip in the 3 AM values. These may not be recognized, but they are there, and they may be then impacting the morning high subsequently. So what can we do when we see this? Reduce the dose of basal insulin, ensure a bedtime snack, and if they were having a late evening exercise, they should avoid that altogether. Remember, in a type 1 diabetes patient, exercise can result in an immediate post-exercise high, but not uncommonly a late post-exercise low. Very important to understand. So the pattern here is clear. You need to fix the sugar, which is most abnormal and the earliest, and which may have implications for the rest of the log. Fix this, then see how the morning sugars are behaving. Because if you can look at this log, the post-meal rise is not significant. It's about 50 or 60, which is slightly more, about 30 here and about 50 or 60 out here. They may need a little tweaking in their pre-meal regular insulin, but primarily what needs to be fixed first is the 3 a.m. value. What about this individual? Now, the only time when we have the only abnormal values are in the evening. So all the pre-dinner values are high, but again, the post-meal increment is not bad. So clearly, we don't know what's happening in the post-meal period out here. So we don't know whether the regular dose is all right at breakfast and at lunch. We clearly think that the regular dose before or the bolus dose before dinner seems to be all right because the post-meal increment is acceptable. But clearly the before dinner value is elevated. So we don't know whether this elevation happened from immediately after lunch or happened sometime in the evening. So check the after lunch reading. If that is also all right, see what's happening in the evening snacks. If they're also all right, increase the basal dose in the NPH dose in the morning. And once you fix that and this becomes low, you will need to fix the nighttime NPH because otherwise you will precipitate a 3 a.m. low. So again, systematically analyze the information and make those changes. And here's another example. Again, we don't know what's happening post meals out here, but very clearly there's a big jump after dinner. So maybe there's a problem with the content of the meal. We are hampered by the fact that we don't know what's happening here, and we should also test there because for all you know, the same phenomenon is happening after each meal, but at least we can start by the dinner. Look at the dinner portion, look at the quality of the dinner meal, and increase the bolus dose before dinner. Very important to look at patterns of math. So let me stop here. I know it's a lecture which would be as much in place in a program 20 years ago as it is today. But unfortunately, these are very basic principles of management. And we sometimes tend to forget that because we get enamored by or distracted by newer technologies. But even with the newer technologies, unless we're in a position to capture, analyze, interpret, and react, those technologies are of no use. Monitoring is being done to enhance the ability of the patient to self-manage, empower the patient, and inform the physician to improve glycemic control and improve patients' outcomes. Let me stop by saying that blood glucose monitoring is a fundamental part of optimal diabetes self-management. It also assists physician management. These devices have become smaller, more accurate, require less blood. As an internal medicine resident, I still remember using meters, which we used to wait a minute after putting the drop of blood on the strip. Then we had to go to a tap, wash the strip, blot it with tissue paper, then put it into the meter. So, we need to spend about 2 minutes per patient. And if you were in a busy ward, it was very, very frustrating. Now you get your answers in 5 seconds. No washing, no tissue paper, no nothing. The standards required to gain FDA clearance have become more stringent, and more accurate glucometers are now available in the marketplace. But I also flagged the point that in that particular paper in which 17 meters had been analyzed, 5 out of those 17s actually went beyond FDA thresholds. But I think the message I really want to communicate very clearly out here is that blood glucose monitoring is only helpful if the person with diabetes and their caregiver, if they're a minor, know how to view, interpret, and act on their results. Otherwise, it's just a piece of paper or it's a lovely WhatsApp snap. The recommended frequency of blood glucose monitoring should be individualized in type 1 diabetes between 4 to 6 to even 10 times a day, but definitely as far as possible, if the economy permits, at least 4 times a day. For people on oral agents in type 2 diabetes, maybe structured monitoring at a time when the dose is being changed or there's an intercurrent illness or an acute hyperglycemic phase. GDMs 4 times a day at least until they go on basal bolus when they require it as frequently as anybody on basal bolus, whether it is type 1, type 2, which is about 4 to 10 times a day. I will stop here and thank you so much for listening to this rather ancient talk, but I think a talk which is still very relevant for our day-to-day clinical practice. Thank you so much.